Hello, good morning. Welcome everybody to our second Life After Stroke webinar today. Thank you to everyone who joined us this morning for the Back to Work session. I hope you enjoyed that. And thank you for everyone who is now joining us for the Fatigue After Stroke session right now. And I hope many of you will return and join us for our last session today on physical exercise after stroke. I am Arlene Wilkie. I am the Director General for the Stroke Alliance for Europe, and we advocate for improvements in stroke care and support across the whole care pathway throughout Europe. We set up the Life After Stroke Forum in 2019 as there were few opportunities regarding conferences, workshops and shared networking opportunities for advocates and researchers in life after stroke. During 2021 and 2022, we have held a series of successful webinars, and in 2023, we'll be holding our first face-to-face event in Barcelona on the 10th of March next year. This will be our first opportunity to meet and get you all together in person since the pandemic. And more details of this event will be found at our forum website, and we will share the link with you at the end of this session. Before I introduce the chair of the session this morning, I would like to thank a few people. Firstly, I would like to thank the scientific committee for all their help in putting together the content for this session. I would also like to thank our sponsors and also our endorsers as well. And at the heart of all our events are people who live with stroke. Their experiences are central to our sessions today, and I would like to thank every single stroke survivor who has put the time and effort into working with us on the programme and also on their contributions. I hope you enjoy the session. Today is accredited, so you can receive 1 CPD point from this session. You will need to complete a feedback survey, which we will send to you after today. If you attend all 3 sessions, you can get all 3 CPD credits. If you wish to tweet about the event, please use Life After Stroke. If you want to use some subtitles, there is a CC button at the top right of the stream window. If you click on that, you can get subtitles. I encourage you to ask questions throughout the presentations. Questions through the Q&A section on the right of your question. Our speakers will form a live panel at the end of the presentations, and they can respond to your questions. Please say hello in the chat function so we know that you are there. What I'd like to do now is I would now like to introduce the chair of the session. The chair of the session is Avril Drummond. She is Professor of Healthcare Research at the University of Nottingham and the chair of the European Life After Stroke Forum Committee member. And this session is on fatigue after stroke. What can we do? And I would now like to hand over to Avril in just a minute. Thank you.
So, welcome everyone to this session on post-stroke fatigue. I'm so glad that you're able to join us in this very important session. And I'm actually the warm-up guy, but I've got 3 very eminent speakers following me. So as you've already heard this morning, my name is Avril Drummond. I'm a stroke rehabilitation researcher, and I'm based at the University of Nottingham. And I have a particular interest in post-stroke fatigue, which is why I'm chairing the session today. So one of the first things I want to say is that the word fatigue is becoming very commonly used in everyday society. And of course, this is very frustrating for many people who have really complex, genuine fatigue because of a number of conditions, including stroke. And what we want to do today is to really underline what fatigue really is and perhaps some of the strategies that may help people. So a couple of the key characteristics, first of all. So people use the word exhaustion or wiped out when they're describing what they mean. They seldom talk about being tired. They talk about a condition that's chronic and ongoing, and they talk about a condition which is unrelated to what they've just been doing. So putting it bluntly, if you ran a marathon, you would expect to be exhausted. But many of the people who have fatigue are doing activities which result in them feeling fatigued for no apparent reason. It doesn't tend to get better with rest or with sleep, and it's often very unpredictable. And of course, it is worthwhile saying that post-stroke fatigue can be both physical and it can be what many people describe as having a brain fog. We've known for many years, many years, that fatigue is one of the most distressing symptoms that people report after their stroke. But it is really only in relatively recent years that stroke researchers have become very interested in it. And in the UK, it is now a priority area and has been for several years. It is an international issue. For example, it's in the Action Plan for Stroke in Europe, and you will find it in many international stroke guidelines. So we absolutely recognise that this is an area we need to address and we need to do better in. So how many people actually have this post-stroke fatigue? Well, this is a problem because we don't really agree. And the reason that we don't really agree is that people define it in different ways, and it depends when you ask people with their stroke about fatigue. But generally, if you look at the literature, there is a feeling that about 50% of all people who have a stroke experience fatigue. And it's important not just because it makes people not feel good in themselves and it affects their quality of life, but it's also important because it affects people being able to participate fully in their rehabilitation, and because of that, it often is associated with a poorer functional outcome. So fatigue is serious and we need to talk about it. And one of the things that we have found in my own research group is that many people say that no one has actually ever talked to them in a professional way. And so that is one of the reasons why we're running this session today. So we want you to do a couple of things. We want you to enjoy the session. We want you to learn from it, but we also want you to participate and to ask us questions about what's going on at the end. So let me introduce my three excellent speakers. The first speaker is the real expert. Ruth Miller is from England, and she's a stroke survivor who has fatigue and who has aphasia. And she's going to tell us a little bit about her experiences and how she manages. Next up, we've got Professor Gillian Mead from Scotland, and Professor Mead is an international expert in this area, and she's going to tell us what we really need to know. And last, but by no means least, we have Anders Lærdal from Norway, and he is going to talk about research from his group about measuring fatigue, because obviously it's really important, if we recognise that people have fatigue, that we can look at the levels they have and whether any particular strategies help. And at the end, this will be the audience participation. And so we're asking you to post your questions so that we can have a group discussion. So please enjoy this session, and I'm very pleased to welcome first up Ruth Miller. Thank you.
Hello, my name is Ruth Miller and I am a stroke survivor. I had my stroke 6 years ago. So why am I so tired? Today I will talk about my experience of fatigue and how that I will manage it. My life before stroke was straightforward. Work, home, others. This was me. A bit tired at end of work and travel, but never felt fatigue. Then bang, my stroke after I got home from work. My life changed in 5 minutes. 3 more months in hospital. My body told me to rest. Slowly getting back with NHS, with family and friends, later with the Stroke Association, put me together best as they can. So, what can it in the living, beg your pardon. So, what is like living experience? My fatigue. Not just a bit of being tired. This slide shows some of the effects. It is frustrating and hard work. I has nearly died. I want to live in every moment, not lying down. It feels like world and people are going around me. That is exactly how I feel. It is real hard work, but I realize that I can do it. I tell myself, I will let you read these. I think of a way or I can manage it happen. And my skiing has improved. Give us the way, Mum. I needed a rest after that, but I did it.
Good morning, everybody. I'd like to thank the organisers for the opportunity to speak to you today about fatigue after stroke, associations, prognosis and treatment. So today I'll discuss what fatigue is like for stroke survivors. I'll show how it's a research priority. I'll discuss prevalence, associations and management. So I see quite a lot of stroke survivors in my Life After Stroke clinic who have fatigue, and these are some of the descriptions that they've provided. I've never had fatigue like this before. I can't get back to work because of my fatigue. I hit a wall and must rest. Being with other people and talking is exhausting. Some people say that they need to sleep a lot during the day, or some people say that my sleep is fine. And it's clear to me that fatigue is not the same as sleepiness. Last year, the Stroke Association did a priority setting partnership with the James Lind Alliance to identify research priorities, both in the area of acute care, also secondary prevention and life after stroke. And these were the top 10 priorities for life after stroke research. And what you can see here is that understanding fatigue and how to reduce it is the fourth top priority. So how common is fatigue after stroke? This is a meta-analysis performed by Toby Cummings in 2016, where he identified all studies that had used the fatigue severity scale as an assessment tool. This is one of the many fatigue scales that's available, but it tends to be the most commonly used in stroke research. And as you can see, there are quite a large number of studies, and the proportion with fatigue, the summary estimate was about 50%. But of course, there's still quite a lot of heterogeneity here. But so around 50% of people after stroke will have fatigue. So how can we identify and measure it? I like to think of fatigue in terms of identifying it first and then measuring its severity. And you can identify it using a formal case definition and structured interview. And fatigue has to interfere with daily activities. And we published this a few years ago. So it's analogous to the case definition that exists for chronic fatigue syndrome. There's also a much quicker tool called the Greater Manchester tool, which is really used to screen for fatigue. And this asks two questions. Do you have fatigue? And would you like additional help and support for this? And we use this in our positive trial, which I'll describe later. So as well as identifying fatigue, it's important also to measure its severity. And there's about 50 fatigue scales to choose from. And when you're considering which one to use, it's important to think about validity, reliability, and responsiveness to change. We use the fatigue assessment scale and the vitality component of the SF36 in our research. But as I've alluded to just a minute ago, others often use the fatigue severity scale. There's no consensus at the moment about which scale is best to use, but hopefully we'll be providing some guidance for this when we publish the results of a round table on fatigue sometimes next year. So moving now on to the associations of fatigue. Associations are important because they might provide potential targets for treatment. So when the fatigue literature after stroke started to develop, it was initially felt that brainstem strokes were more likely to have fatigue, but this seems not to be the case. There's also some evidence that inflammation might be relevant fatigue, but the size of any link is unclear, and there's very few studies that have formally looked at this. Of course, measuring CNS inflammation is tricky, and perhaps one way forward is for researchers who were already measuring inflammation in the brain, perhaps using PET imaging, might want to add fatigue scores to their studies. What we do know is that there's definite associations with depressive symptoms and anxiety symptoms, and some smaller studies suggesting associations with poor coping, loss of control, pain, poor sleep, and also pre-stroke fatigue. When we started work in this area a few years ago, we were aware that in conditions other than stroke, fatigue was often related to being less active and less fit. And this applies, for example, in people with cancer fatigue. So we wondered whether the same might apply to people after stroke. So we measured physical activity using an active PAL. This is a small device that you can place on somebody's thigh over a 7-day period or for however long you want to record the data for. And it gives you measurements of step counts and time upright and time asleep. And what we found was that lower levels of activity early after stroke predicted later fatigue. On the bottom slide, you can see a picture of a gentleman doing a leg extensor power test. And this is just one aspect of fitness. And I think we currently don't know for sure what the relationship is between being less fit, both aerobically and from the strength and power perspective, but there are some associations. So we then, based on these data, developed a pathway or a model for fatigue after stroke, starting with pre-stroke fatigue. So if you've had fatigue before your stroke, you're more likely to get it afterwards. On the acute stroke unit, probably a trigger for fatigue exists. There's possibly something about the stroke lesion that triggers fatigue, and we think also that physical inactivity does. And then there's these perpetuating factors here, which exist both on the rehabilitation unit and after discharge. So based on that model and the potentially reversible factors, we developed a brief behavioural psychological intervention for post-stroke fatigue, which consisted of 6 sessions, each 2 weeks apart, face-to-face with a clinical psychologist. We gave the psychologist and the patient a workbook, and the intervention targets known factors. So it looks for any problems with sleep, it looks at how active people are, and it also looks at negative thought patterns. And the focus of this intervention is that fatigue is treatable and reversible. And we published these data about 5 years ago now. So here are the results. So this was an uncontrolled study in a small number of patients, but what you can see is that fatigue assessment scale scores do drop between baseline, post-treatment, and interestingly continue to drop after treatment, suggesting that perhaps participants are continuing to put into action some of the techniques that they've learned during the intervention period. So these data were promising, and based on this, we obtained some funding from Chest, Heart and Stroke Scotland to run the POSITIVE trial. Now, because clinical psychologists are in short supply and because some of the practical challenges of face-to-face meetings, we adapted the intervention, 6 telephone sessions over 12 weeks with a nurse who was trained in intervention delivery, and then what we called a booster session at 4 months. We identified eligible patients from 3 hospitals in Scotland through a variety of different methods. We sent them a consent form and screening questionnaires to identify those with fatigue and who did not have serious mood disorders. Of our 75 eligible patients, we randomized them then to the POSITIVE intervention plus information alone, and this information was a stroke association leaflet, or information alone. And then we did 6-month central follow-up by telephone, post or online for the primary outcome, which was our fatigue assessment scale, and a number of secondary outcomes. So here now are the results from our trial. So this shows the mean difference in the scores between groups. So this is the fatigue assessment scale at 6 months. And there was more benefit in the intervention group, as indicated by a minus score, but this did not reach statistically significant values. And similarly for the 4-month data on the fatigue assessment scale. It was better in the intervention group, but not significantly so. And the direction of the benefit for our PHQ-9, a depression measure, and for the GAD-7 anxiety were also in the right direction, but none of them was statistically significant. But what was interesting was when we looked at the longitudinal changes in fatigue, we found that the fatigue scores fell in both groups by around 4 points between baseline and 6-month follow-up. And this represents a clinically significant fall. And the PHQ-9 and GAD-7 scores also fell. And this suggests to us that perhaps giving somebody a leaflet or perhaps just enrolling them in a trial of fatigue helps improve outcomes, or perhaps this just reflects natural recovery in fatigue over time. So there have been some other trials in post-stroke fatigue. So there's quite a lot of interest in modafinil, which is a stimulant. There's been 2 small trials, unclear effects, and a larger one is now being set up and led by Christopher Levy from Australia. There's also been a lot of interest in SSRIs. We know from our own FOCUS trial that SSRIs do not prevent fatigue if given early after stroke. And they don't seem to be an effective treatment. Although a lot of people with fatigue, when they go to their general practitioners, there's an assumption that they might be depressed and they get put on an SSRI. There's also been various different psychological approaches which seem to have small benefits in some small trials, but there's methodological problems. And there's some really interesting work coming out now from Anna Kupaswami's lab in London, which shows that transmagnetic stimulation might improve fatigue. So there are definitely some promising avenues for future research. So here are the data from our FOCUS trial. This trial mainly aimed to find out whether giving fluoxetine within the first 14 days after stroke improved recovery at 6 months as measured by the modified Rankin score. And we also measured a number of other important clinical outcomes. And we found that fluoxetine did not reduce disability or improve recovery, and also it had no effect on fatigue at 6 months. Although interestingly, it did reduce the number with depression. So there is no indication for giving fluoxetine early after stroke to try and prevent future fatigue. There are a number of different guidelines about post-stroke fatigue, and here's a scientific statement from the American Heart Association. Admittedly, this is a few years ago, but it does recognise that education materials should be provided to patients and families, and that family support is probably helpful. The Canadian guidelines from 2019 go a little bit further and recommend that healthcare professionals who are knowledgeable about fatigue should be involved in management. Modafinil is mentioned, which I've already discussed. Psychotherapy is also mentioned, possibly mindfulness, counselling on graduated exercise and energy conservation. But as you will see, these recommendations are all level C evidence or level B. And I think this really demonstrates the need for future research. So how do I manage fatigue in my life after stroke clinic? This is a clinic that was set up about 4 years ago, and our aim was to review people after discharge who had ongoing problems post-stroke. And I see a number of different problems, commonly fatigue being one of the main ones. Also, post-stroke pain is actually quite relevant, sometimes deterioration in function and cognitive impairment too. But with respect to fatigue, I think the first important thing is to listen and validate that fatigue experience. Explain it's a common problem after stroke, even a minor stroke. We know that it often gets better over time, and we're just completing a piece of work where we're looking at longitudinal cohort studies, and it does seem that at least half of the people with fatigue will get better over time. We also recommend that pacing is important. What I find is that some patients really want to get better, they overdo things, they become very tired, and then they have to rest for long periods. So this boom and bust type pattern of activity is probably not beneficial. So whilst we want to improve activity levels, we want to do this gradually. I also explore sleep patterns and suggest to people that they avoid caffeine and alcohol before bed. And I also recommend exercise. And I know that there's no direct evidence about the benefits for fatigue after stroke, but I think there's a lot of circumstantial evidence that this is a reasonable thing to do. We know that exercise improves fatigue after cancer, and there's some good randomized trial evidence. There is also loss of fitness after stroke, and we know that exercise training improves in other important outcomes after stroke. I also give the Stroke Association leaflet about fatigue after stroke, and I usually go through that leaflet with patients and perhaps circle things that are particularly relevant to them so that they feel that the information has been tailored towards their specific needs. Just a word about fitness. We know that fitness after stroke is impaired, and this applies both to aerobic fitness and muscle strength and power. And after stroke, around 50 to 60% deficit of age-matched controls. But actually, what's required is you need greater levels of fitness. So, for example, if you've got a hemiparesis, impaired balance or coordination, your oxygen cost of walking is higher than age-matched controls. So there's a big mismatch between the fitness needed and the fitness available. And for this reason, we recommend implementing fitness training after stroke. And this is now included in most of the major stroke guidelines. And in Edinburgh, we've developed an exercise after stroke program, and we aim to refer patients with stroke, irrespective of whether they've got fatigue or not, into this program. But we need more research in this area, and these are some of the areas where research is needed. I think particularly barriers and motivators that's absolutely key. So where next for post-stroke fatigue? Well, firstly, we need more researchers working in this area. There's a handful of probably about 10 people in the entire world who are active in this area, including myself. And that's quite astonishing when you think that 50% of stroke survivors have fatigue. There's still questions about how best to measure fatigue, which is the best scale, and possibly can we simplify existing questionnaires, perhaps by using factor analysis to identify one or two items that pick up the key essence of fatigue. We certainly need a better understanding of neurobiological processes. Is this related to neurophysiology or perhaps inflammation? And finally, we need large, definitive, randomized controlled trials of complex interventions, such as those used in our positive trial. Before I finish, I would just like to mention post-COVID fatigue and draw some analogies. The literature on post-COVID fatigue is expanding at a rapid rate. And very interestingly, the advice is similar to that we currently give for fatigue. It's about recognition, sleep, possibly relaxation, prioritizing, activity diary, keeping active, and eating well. Another just interesting point I'd like to make is that the fatigue literature on COVID and stroke COVID is expanding rapidly. So by August, there were already 501 citations on Medline, even though COVID has been with us for under 3 years. This already exceeds the number of Medline citations on post-stroke fatigue of 360. So again, this emphasizes the need for more work in stroke. But interestingly, the post-COVID fatigue, these Publications are focused on measurement, mechanisms and management, and that's the same approach that we're taking in post-stroke fatigue. So in summary, fatigue after stroke is common and debilitating. There are definite associations with inactivity, low mood and anxiety. Management should involve education and paced activity. And of course, if there are mood disorders, then they should be treated. And more research is needed. And I'd like to finish by thanking the funders of this research over the years. And thank you very much for listening.
First of all, I would like to thank the organizer of this conference for inviting me to talk about the measurement of post-stroke fatigue. This is an important part of our work at the Norwegian Study of Fatigue After Stroke research group called NOFAST, located in Oslo, Norway. The overall aim of NOFAST is to identify different types of post-stroke fatigue, so-called phenotypes, with different causes and associated symptoms and impairment. In order to do so, we need a good, valid, and reliable measure. I would like to acknowledge the NOFAST research team. For this talk, I will present much of the work from the peer student you see in the middle of the picture, Ingrid Johansen Skogstad. The objective of her PhD study is to develop a new tool to measure fatigue that is specific to stroke survivors. I also want to acknowledge the Stroke Recovery and Rehabilitation Roundtable. I'm lucky to be a member of this group, and our overall aim is to discuss and agree on the future direction on post-stroke fatigue research and knowledge development. In my talk today, I will address several questions I see as important for this topic. First of all, we need to know and decide what to measure and when to measure it. So, in order to measure post-stroke fatigue, we need to ask the basic question: what is fatigue and what aspects of or dimensions of it are important to measure? This can vary depending on our goal or purpose. For example, do we want to know if it is present or absent? How often is it experienced? How severe is it today? How distressing is it? What makes it better or worse? Or how much is it interfering with daytime function? When we know what to measure, we can start discussing how to measure it. I will present for you our group's results from a review we published in 2019, describing the most frequent used scales that stroke researchers have used to measure fatigue. At the end of the talk, I will propose a kind of map that is based on these findings, and that I believe we can use to understand findings from existing studies on post-stroke fatigue, and can help us to select the best fatigue measure when we want to accurate estimate of special types of fatigue. We know that there is a wide variety of patient-reported fatigue measures in use. We found none developed specifically for stroke patients. Based on this knowledge, we decided to review the most relevant fatigue measures used in stroke research and evaluate their content validity. We also wanted to compare their content in order to identify similarities and differences. For your information, this article is published open access. You can Google it and download it for free. We searched research databases in order to find all fatigue measures used in stroke studies. We selected the 8 most frequently used scales for further investigation. In addition, we included 3 measures that were adapted or tailored to stroke patients. These scales included a total of 156 items that formed the basis for our content analysis. When we analyzed these items, we found that some items were very similar or obviously overlapping by using similar concepts in the question. When we took this overlap into consideration, we identified 83 unique items, each representing a distinct attribute of fatigue. You can see the findings summarized in this figure. Each color circle represents a fatigue measure, and each dot represents one item. I know the text is too small, but it illustrates that fatigue is measured with different items in the different scales, and that the different measures have relatively little overlap. Because of the different measures of fatigue addresses different aspects of fatigue, it's very difficult to compare findings from studies using the different scales. I'll come back to that later. From analyzing the content in these unique attributes of fatigue, we agreed on 4 main categories of the items. These were characteristics of fatigue, its severity, fatigue interference, and individuals' management of fatigue. When we organized items from all measures into these 4 categories, there were only 2 scales that addressed how individuals manage their fatigue. The most widely used scale was the fatigue severity scale. This scale was used in 37 different research articles on post-stroke fatigue. When we researchers are designing a study on post-stroke fatigue, I believe we have an obligation to clearly describe and explain for the readers and the audience what aspects of fatigue we are measuring. A complicating factor is that the name of the measurement tool does not necessarily represent the main dimension of fatigue that it is aimed to measure. A good example of this is the fatigue severity scale, which is the most widely used scale in stroke studies and also in chronic illness in general. Because of the name, we intuitively believe that it measures fatigue severity. But in fact, when you analyze the content of the question it measures in the scale, it captures fatigue severity only to a minor degree. The major dimension it addresses is fatigue interference. When other research groups reviewed existing fatigue measures, we noticed that several of the measurements contain questions that may be related to the consequences of stroke and thus may cause measurement errors when our attention is to measure fatigue. For example, in the childhood fatigue questionnaire, one of the questions is, do you have less strength in your muscles? Since stroke patients may have physical impairments due to the stroke, a yes from a stroke survivor on this question may reflect the physical impact of the stroke, but they will score on fatigue. This fatigue questionnaire may be a valid scale for the general population and is frequently used. However, in people with neurological diseases, it would not be ideal. Furthermore, some scales have a high number of items and may be so long that they are fatiguing to complete. While we have evidence of relationships between post-stroke fatigue and pre-stroke fatigue and level of physical functioning and even the present symptoms to some degree, there is inconsistent findings regarding relationship between fatigue and other factors such as sleep problems, pain, cognitive functioning, anxiety, and stress. One of the reasons for this is that the fatigue scales used in stroke measure different dimensions. In order to advance research on post-stroke fatigue's etiology and treatment strategies, we need an instrument that captures the pure phenotype of specific experiences of patients with post-stroke fatigue without confounding fatigue symptoms with other stroke symptoms. Our research group NOFAST has taken on the responsibility and is in process of developing a new measure of fatigue in stroke survivors. Our first step was to design a qualitative study. We performed individual, semi-structured interviews with stroke survivors with fatigue. Our multidisciplinary focus led us to several focus groups interviews with experienced health care workers providing health service to stroke patients. We also interviewed 9 stroke survivors and over 18 years of age from Norway. They all experienced a stroke less than 2 years ago and were diagnosed with post-stroke fatigue based on a diagnostic interview using the criteria published by Lynch and colleagues with Gillian Mead as the senior author. Both of the stroke survivors and the healthcare workers describe post-stroke fatigue as a complex and multifactorial phenomenon. The individuals who experienced a stroke described characteristics of post-stroke fatigue in 5 categories: quality, intensity, diurnal variation, restitution time, and invisibility, as you see in the figure from our publication. The stroke survivors describe fatigue quality as either mental, physical, or general fatigue. Severity varied from manageable to total exhaustion. Their fatigue varied during the day, described as diurnal patterns in the model. When they experienced fatigue, they needed time to restore. For the fifth category, invisibility, they reported that the family members and others had difficulty recognizing their fatigue because it was invisible. Fatigue interfered with and could be aggravated by factors such as emotions, cognitive performance, activity in daily life, and participation in social situations. In the acute phase of fatigue, both patients and healthcare workers perceive fatigue as a normal reaction to illness. However, after some time, they became more and more aware of fatigue if it caused a problem with their performance and participation in daily routines or social situations. Our studies show that the most commonly used post-stroke fatigue measure did not address potentially relevant aspects specific to fatigue in stroke survivors, such as diurnal variations and pre-stroke fatigue. Furthermore, these measures do not account for the multidimensional nature of fatigue. Our analysis suggests that these fatigue measures have critical limitations and potential bias that could impair further progress in post-stroke fatigue research and patient care. Our analysis relieved 83 unique fatigue-related items in 11 measures used in stroke research. We classify the items in 4 main dimensions covering different fatigue-related aspects. Despite the consensus that fatigue is a multidimensional phenomenon, the 3 most widely used patient-reported outcomes in post-stroke fatigue research is fatigue severity scale, the visual analog fatigue scale, and the SF-36 vitality dimension, mainly assess fatigue characteristics or interference. One previous study evaluated fatigue measures used in stroke research considered fatigue severity scale to have insufficient face validity. Why the fatigue scale is the most preferred fatigue measure in stroke research is not stated. But it was developed initially, tested with adults with multiple sclerosis or lupus, and the fact that it has become the most widely used fatigue measure for stroke illness research may be the reason. Since the measure is now used in several different patient populations, it is possible to compare research findings on fatigue across groups with different health problems. Given our understanding of post-stroke fatigue as a multidimensional phenomenon, we've reached 2 conclusions in our published review: that the consequences of stroke should not be included as part of the assessment, and we do not have a gold standard measure for fatigue in stroke survivors. Based on our conclusion, you are probably wondering how I can take on the task of giving this talk on how to measure post-stroke fatigue. Well, my answer will be that first of all, we need knowledge about what the existing scales actually measure. Based on intention of what dimension of fatigue we want to measure, we select the best scale according to our aim. The aim of measuring fatigue can be quite different in the main purpose of research, if the main purpose is research or clinical use. For clinical use, we might be most interested in how much fatigue interferes with daily function or management of fatigue. Knowing that stroke survivor is having trouble managing their fatigue may indicate that they lack knowledge of how to manage it and maybe benefit from a teaching intervention. If the aim of the research study is to identify possible types of fatigue, we may select a scale or scales that distinguish the 5 characteristics of fatigue mentioned earlier from our interview data. From the rest of my talk, I will focus on the 6 existing scales that I currently see as the most promising for use with stroke patients. The fatigue severity scale is far the most widely used instrument to measure fatigue in stroke survivors. It was originally developed to assess fatigue in individuals with MS or lupus. The psychometric properties have been tested in stroke samples in several studies. The original version with 9 items measure to some degree characteristics and severity, but overwhelmingly addresses fatigue interference. The fatigue assessment scale was developed to measure fatigue in the general population. It has 10 items and predominantly measures fatigue characteristics and to less degree severity and interference. Items are focused on physical and mental fatigue. The multi-dimensional fatigue inventory was developed to measure fatigue in individuals with chronic fatigue syndrome. It has 20 items. Similar to previous fatigue assessment scale, it predominantly measures fatigue characteristics and to less degree severity and interference. It is frequently used in stroke research and measures 3 or 4 dimensions. It has 5 subscales: general fatigue, physical fatigue, mental fatigue, reduced motivation, and reduced activity. The Dutch multi-factor fatigue scale is a 38-item, relatively new scale developed to measure fatigue in individuals with acquired brain injury, where individuals with stroke are the largest group. It measures all 4 domains: characteristics of fatigue, severity, interference, and fatigue measurement. It has a relatively high number of items, and when we reviewed the content, we concluded that it measures 4 out of 4 dimensions. The scale has 5 subscales: physical fatigue, mental fatigue, impact of fatigue, signs and direct impact of fatigue, and coping with fatigue. The Dutch multi-factor fatigue scale is a 38-item, relatively new scale developed to measure fatigue in individuals with acquired brain injury, where individuals with stroke are the largest group. It measures all 4 domains: characteristics of fatigue, severity, interference, and fatigue management. It has a relatively high number of items, and when we reviewed the content, we concluded that it measured 4 out of 4 dimensions. The scale has 5 subscales: physical fatigue, mental fatigue, impact of fatigue, signs and direct impact of fatigue, and coping with fatigue. In conclusion, we have several fatigue measures that have been used in stroke research. Different scales measure different dimensions of fatigue, including some describe as cognitive and others describe it as mental. When we compare findings from different studies, we need to take into consideration what dimensions are actually measured and with these different scales. When we select a fatigue scale for clinical or research purpose, it is important to define the aspect of fatigue we want to assess or measure, and then select the scale that best covers that dimension. For example, if a patient say he or has fatigue every evening. In conclusion, we have several fatigue measures that have been used in stroke research. Different scales measure different dimensions of fatigue. When we compare findings from different studies, we need to take in consideration what dimensions are actually measured with these different scales. When we select a fatigue scale for clinical or research purposes, it is important to define the aspect of fatigue we want to assess or measure, and then select the scale that best covers that dimension. For example, if a patient says he has fatigue every evening and the clinician suggests an afternoon nap every day, the goal is likely reduced frequency or less intense fatigue in the evening, which could be measured in that relevant dimension. If the clinician suggests adding physical activity 3 times a week, or the researcher is testing this intervention, an improvement in fatigue severity may be assessed daily or weekly, and the focus may be on physical fatigue rather than on mental fatigue. Finally, we need a better consensus regarding what measure to use in future fatigue research in order to develop important knowledge and more targeted and effective fatigue treatment strategies. Thank you for your attention.
So that's wonderful. I think the audience have to agree that we've had 3 excellent speakers today, and I can honestly say that I have learned things that I didn't know. So I want to invite my speakers back onto this virtual platform because there are many questions, and I'm going to try, I don't think we're going to be able to answer them all, but I'm going to try and jump between the chat and the question and answers. So the first thing is, people have been terribly complimentary. We're just trying to get Ruth back at the moment. People have been very complimentary, but Ruth, I think you actually got a fan club going here in the chat, so we might have to sign you up for another gig after this. And Ruth also has Bill in the background here, who's her husband, who is going to help her a little bit as well. So hi to Bill. Okay, so can I just direct you as well to the poll? We asked you a poll about your confidence in stroke at the beginning of the session. So I'd really like you to go back into that poll again when you get the chance and tell us if this session has helped you. So where am I going to begin with all the questions? I'm actually going to begin with Ruth, because I'm sorry to say this, but I think that you were the star of the show today and have stolen everybody's thunder. So
Thank you.
can I ask you which of your coping strategies you think is the most effective?
Yes, I think it's the plan, everything, and so that you're rested, and that means that you don't so worry. You know you're rested and time to get into the next activity. This is showing off somewhat. I did a walk up in excuse me, the Delphi in Greece, and I would know that I wanted to do that, and so I rested very early to imagine that and getting up there.
Okay,
so planning.
So you're talking about planning, which many of the health professionals call pacing. So these are all just different terms for the same thing. Yeah. Gillian, I'm going to come to you and say, what feedback do you have from your patients and the stroke survivors that you see about what they think are their top tips for managing fatigue? And you're actually on mute at the moment.
Right, yeah. I think it varies actually. I think different things work for different people. I think some people have certainly found getting fitter really helps. So I've had people who've gone back to swimming, not having swum before, and they come back and they say their energy levels are much, much better. I think for some people, particularly with mental fatigue, and it's often looking at a computer screen for long periods, they find that having breaks in between that helps them to keep going rather than just hitting a wall late afternoon. And I think people who perhaps aren't sleeping very well, or they're having naps during the day, which we know probably interferes with sleep later on, I would really be kind of trying to tease out what's happening with their sleep patterns, and perhaps try and encourage them not to sleep during the day and then have a good sleep routine at night, trying to go to bed at the same time. I've had some success as well with some patients who've had really poor sleep patterns, perhaps going to bed late, tossing and turning, but then sleeping in until about 10 or 11 in the morning. So sometimes using a sedative at night just for a very short period or even a couple of nights to get the sleep pattern back into more normal pattern and getting up earlier helps. So I think it really depends on the nature of the fatigue, and that means you have to listen to the stroke survivor in front of you. So there isn't any standard recipe, but I think it's tailoring your advice to individuals is really important.
So I think that's a great answer. And I have to say, that's my experience as well, that there isn't one strategy. And so people need to be confident, and therapists and clinicians need to be confident in suggesting a number of things to people which they need to be trying out. The next question actually is also for you, Gillian. And it's really, I think people have been posting on the chat well about, do people really respond well to doing exercise when they're saying they're fatigued? I think that's a great question, by the way.
Yeah, absolutely. I think it's really it's very challenging. I think the point at which I start is to say that after stroke, we know there is often very serious physical deconditioning, both aerobically and muscle strength wise. And we think that probably is associated with fatigue. And I think the way potentially to break that cycle is to do very, very tiny amounts of exercise to start with, and do it so that you kind of do it to the point where you may feel slightly tired and then stop, and to really try and build that up gradually. So I think it is a difficult conversation, and I think there is, if you've got really bad post-stroke fatigue, the idea of actually doing more and being more physically active seems counterintuitive. So I think that conversation has to be done in a very collaborative way, exploring the barriers and really suggesting to people that it's a strategy that can work and it's worth experimenting in and giving it a go. And I think it's encouraging people to try it and also be aware that it's not going to harm them. I mean, the worst that will happen is they might overdo it and feel tired for a day or two afterwards, but it's very difficult, and I totally respect the views of stroke survivors. And I think if you're suggesting anything, it has to be a shared decision.
Yeah. So I think that's a really great point. And I think going on from what Gillian's been saying, that, I think there is a lot of worry about doing exercise and about having another stroke. And those are genuinely conversations that people need to be having and talking about, because that often is the fear that people have. Anders, you've been getting off very lightly at the moment, but not for long. And again, just following a thread in the chat, which is, given the fact that so many conditions have fatigue, and given the fact that there are so many measures, and I have to say, I think that you covered this really well, because, there are so many measures, but do we really need a stroke specific fatigue measure? Why can't we just take one off the shelf?
Well, first of all, my presentation was, there is a jungle of fatigue measures, as you say, and even for the researchers, it's very difficult to decide which to use. So, and I think, as I try to explain, there are at least some scales that directly, I would say, measure symptoms or sequels after the stroke, and I think we need to avoid them in order to not to have too much measure errors. But of course, I think also there is a lot of similarities. But in some of my research, we have compared the scales in different patient groups, and they actually function. They are not functioning the same way, actually.
Yeah.
So that's why I believe it's important to develop a scale that is tailored to stroke patients. But I also think that this scale can, to some degree, be used in other populations. So it's a kind of overlap, but I think it's also important to really develop the knowledge in post-stroke fatigue. I think it's important to be more specific than the existing scales are, at least.
Okay, I'm jumping around a bit here, but I'm trying to keep up with the questions here as well. But Ruth, a lot of people are saying thank you for your presentation, which has helped them, and they actually completely understand what you're saying. But what do you think is the worst thing about having post-stroke fatigue? Is there one thing, or what would you say the worst things are? And you're on mute at the moment, Ruth.
Oh, second pardon.
It's okay.
Hold on. Okay.
Okay. For me, the worst is the need to plan and to get enough rest. It makes me worry about the activity in I need rest. Sorry. No, it's just a minute. It makes me nervous. Think about it. I had to think about it too much beforehand, and as I say, that makes me worried that the next thing coming is going to feeling anxious.
Thank you. And actually, it's quite interesting. I did like on your slide where you said about the fact that doing the presentation had also made you feel fatigued. But it reminds me of something some of my patients have said about how exhausted they feel keeping activity diaries. So we say to people casually, keep an activity diary, which will help you plan. But that in itself is a lot of concentrated energy, and you really need to be focusing on what you're doing, and that in itself can be draining your battery.
Yes, indeed. Yes, I do say that in one of the sides.
Yeah, I'm quoting your words now. Okay, there's a question which I'm going to answer, because there is a question asking if we have involved occupational therapists with fatigue management. So I actually am an occupational therapist. That's my professional background. And absolutely, in a lot of the research that we've done, we have been involving occupational therapists and physiotherapists and other health professionals. And a lot of the kind of OT badged energy conservation techniques are very much what we're talking about here. I think, again, we have different language for a very common set of techniques. I'm going to go on to a very specific question for Gillian, which was about the fact that someone was asking about how you are confident that the information helped with reducing FSS and GADS7, so that's the fatigue severity in the GADS, when there was no control group.
Yeah, that's a very good question, and we thought very carefully when we designed the trial about what our control group would be, and we tried to say, well, in best clinical care, what would you do for post-stroke fatigue? And I think because all the guidelines said you would give some information, we felt that we couldn't have a control group who received nothing. So that's why we decided to use the information leaflet. And of course, one of the problems with interpreting that is that we don't know that the fall in the FSS was due to the leaflet, whether it was simply due to being in the trial, or whether it was just recovery over time. And I think we just don't know. But I suppose one has to be pragmatic, and we have to try and learn from that trial. And my take is that, generally speaking, information provision, if it's done actively with the clinician involvement, and this is Anne Forster's Cochrane review, has shown that it does improve, I think, reduce anxiety, and I think improve knowledge. So based on that Cochrane review about active provision of information and the fact that we found that scores did fall, I felt we could justify bringing those leaflets into clinical practice, and that's what I do now. And in fact, behind me I've got a big pile of the Stroke Association leaflets that I do give out in my clinic. But it's a great question, and you're absolutely right, but I still use it with those provisos.
Okay, and there is quite a lot of interest in other conditions where there is fatigue. And I think Gillian actually already mentioned about some overlaps with COVID. So Anders, I'm going to ask you about,
the key overlaps between fatigues and different condition, and is the fatigue the same? And I know that's not a question you can really answer.
No, I think it's difficult to say. I think when it comes to research, we need more in-depth knowledge about defining fatigue and perhaps separate different types of fatigue. We know that people experience fatigue in very different ways. It can be more physically and more mental, and these might need different kind of management. But I would just like to say that I have talked a lot about the kind of measurements that we use in research. I think some of them can be useful when you want to assess a patient clinically, but the most important thing is in the clinical area, I think, is to take a really good patient history and focus on fatigue and let the stroke survivor describe and explain how they experience fatigue, how it varies during the day with activities, and how it impacts the fatigue. And I think that's when the stroke survivors has the best answer in a way.
So one of the things I would just like to say is that from the research that we've done in my group in Nottingham, one of the most important things for me is that we may not have all the answers, but that it is really important to talk to people about their fatigue. And we have people who are several months down the line with fatigue, and no one has ever really mentioned this as a condition or a symptom of their stroke before. And we have tension in families where someone feels that perhaps someone isn't trying hard enough. So I think one of the main things that we want to do in this session is to say, you can try different things. They may not all work, but this is real, and people have a lot of problems in their daily life because of it. And again, people rate this as high a problem as some other aspects of stroke. So I really just want to finish the session here this morning by thanking my three absolutely superb speakers. Honestly, we have had a real whistle-stop tour, and I'd like to thank you as the audience for participating and adding questions. I would just like to say that this will be available on catch up afterwards. So please, if you've missed anything, catch up and do join us later. Thank you.